for the other macular pathologies, macular hole.
Yes, so I'll be discussing about macular holes, pit, and foveoschisis. This is a standard technique, a simple macular hole, a 3-port pars plana vitrectomy. You do a PVD induction with tricot or without tricot. As you can see, most of the macular holes also have a ERM component, so you can see that the PVD is lifting up here over the posterior pole, and the ERM component is also getting removed with the PVD induction. And then you stain the posterior pole with brilliant blue under fluid for about 20 to 30 seconds, and then start the peeling with the pinch and peel technique with the ILM forceps or the end gripping forceps. Just do it circumferentially, remove a ILM flap over the hole, and that ensures that the edges are free of the ILM. This is a standard ILM peeling for macular holes. The size matters, and you should do a sufficiently wide ILM peeling. Indent 360 degree to check for any breaks. Do a fluid air exchange, make it bone dry. You might do some interface vitrectomy also to remove the peripheral vitreous so that a large gas bubble is inside the eye after the surgery. Second is the inverted flap, which was in use after 2010. The steps are the same till now, and then the peeling is started towards the macular hole, and the flaps are peeled till the edge of the macular hole. There is a stump left, which is then cut by the cutter slowly with a low cut rate, and then you can see that the flap is there over the hole and the fluid air exchange is there. So there are problems with inverted flap. So this is our modified approach of doing an inverted flap these days. We instill a PFCL bubble at the posterior pole so that the flap does not get displaced, it does not flutter, and it is stable. So this is the standard technique. After the staining, PFCL bubble is placed over the macula, over the posterior pole, and the peeling is done similarly, and last the fluid air exchange is done. So this is one more case. This will highlight that in the due course of the peeling, the inverted peeling, the PFCL bubble reduces in size, leaks out. So when the PFCL bubble gets reduced in size, there is a slight displacement of the flap under the PFCL. So we reinstill the PFCL bubble over the posterior pole, and to highlight that it's so simple, you just brush the ILM into the hole and it gets reposited in the correct position very easily. You see, just a wave and it gets displaced. Because of the viscous nature of the ILM under PFCL. This is not possible under fluid. So this is a choroidal rupture, a traumatic macular hole, and this video is to highlight that the stability of the macula of the flap, because this patient had a peripheral dialysis and a break also. So we did a thorough indentation 360 degree after the peeling, and the flap did not get displaced. So the flap is reposited in the hole, and after that the peripheral indentation and laser is done throughout the retina, and the flap stays there. So the advantages of this modified approach is that it is easy and reproducible. There is minimum or no fluttering, and the flap displacement, if it occurs, is very simple to reposit. It's least traumatic, and the flap stability during additional maneuvers like indentation and lasers in complicated cases. So these are results. We have done around 40 cases with this, and type 1 closure in all the cases. So we took this idea from macular holes in detached retina. So we are doing the same, the detached retina. After staining, we fill the posterior pole with the PFCL, and under the PFCL, we do the inverted ILM filling in detached retina also. So that has improved our type 1 closure rates, because previously the routine ILM peeling in macular holes with RD resulted in type 2 closures. Macular foveoschisis. I'll show you 2 videos of macular foveoschisis. This is a very high myop. The axial length was more than 31. There was no contrast at the posterior pole. It was a very long eye. So we did the PVD, and then the last highlight remnant was peeled off with the forceps and with the help of a cutter. The instruments were barely touching the posterior pole. So, and there was fluid in the posterior pole, so we injected PFCL. And we are using a high mag lens here, because in such long eyes, when you're using a non-contact wide angle system, your ILM forceps touches the rim of the viewing system. So it's better to use a contact irrigating system or a high mag lens in these cases. So it makes your life simple. And the other point to highlight is that once you catch hold of the ILM, do not leave it, and because once you lose it, it's very difficult to relocate it. And a combined phaco-vitrectomy is the ideal way to do it, because it reduces all the optical aberration. This is one more foveoschisis patient, and the axial length is around 26, 27, so it has a fair contrast at the posterior pole. So we are doing again a PVD induction with the peeling technique. And here, the high mag lens is not used because the instruments are reaching at the posterior pole. So this, the peeling here is done under the reside system, the non-contact wide angle system. Because here the forceps was not touching the rim of the non-contact system. Here again to highlight, once you catch hold of the ILM, just do it very gently, very slowly, re-grasp it again, but do not lose it, because it's very difficult in the poor contrast to catch hold of it again. So in one en masse, the ILM comes out. Optic disc pit, it's debatable which technique works. I'll show you two videos again. This is a lasered optic disc pit, and you can see previously, after PVD induction, we just do a simple ILM peeling in this. And the idea is to remove the ILM edge over the optic disc edge also, and a large ILM peeling is done in this case. So I'm telling you that it's debatable because 100% results are neither achievable in this format of the surgery or the other format like in this, in which we are inverting the flap again in the optic disc pit. So after PVD induction and BBG staining, the flap is inverted inside the pit, and then fluid air exchange is done and gas is instilled. See, the ILM is post-op OCT, it's inside the pit. Thank you.
Vishal, can continue with your next talk on simple RD techniques and.
So you, yeah.
Very nice videos, Dr.
Yes, sir.
So I just wanted to ask
Lights
you were
please.
showing some modifications of the inverted ILM flap.
Yeah.
Now there's a new modification described by the original authors that they are doing only a
temporal
temporal
flap.
flap.
Yeah.
So have you tried that?
Yes, sir. I am doing a temporal flap only. I do not peel it now.
You're not doing
360
it
degree. Yeah, it works
you
fine. It
found
works
good results with that?
fine. Yes, sir.
You found good results with
Yeah,
that?
yeah.
Just a temporal peel?
They are equal to the 360 degree peeling only. Yeah, temporal flap is also.
Thank you.
But what I'm trying to say is that the sub PFCL peeling is it's very stable. You should try.
So after you stuff the ILM,
Yeah.
do you remove the PFCL as well?
I remove the.
At the end of the surgery, you remove the PFCL.
Yeah, yeah.
So at that point of time,
That's
it
what I'm
can
telling
get
you.
detached.
Under the PFCL, the ILM is viscous. The texture changes. So even after the PFCL is removed, it does not flutter. So it stays in position. Yeah. Look, beautiful.
Vishal, mic, please. Yes.
You can check inducing the PVD towards the attached retina whether some hyaloid is left or not. And when you come to the periphery, you can trim the flap of the HST so that a fluid exchange causes the retina to be less bullous. You stabilize the retina with a perfluorocarbon liquid injection and do a further trimming. The suction rates are reduced to 100 or 150 in the periphery. And 360 degree indentation is of paramount importance to prevent recurrences. We all know that. And you go as close as possible as it is safe and do a thorough indentation and vitrectomy. After that, this is the first technique which I'm going to show. I am filling up the PFCL to the interior edge of the primary break. And that is when I'm not sure whether the view will be good under air, when the IOL is subluxated, when there is a lot of PCO. So I do that. I do all my maneuvers under PFCL, fill the globe with PFCL, do the laser, and after air, the only maneuver left is to drain out the PFCL. This is the second technique in which the routine maneuvers are done, the vitrectomy, the peripheral indentation, And here the IOL was stable, the bag was intact. So we go under air and do the laser under air, and then inject the remnant, then extract the remnant PFCL. So this is one more technique of doing it. Of course, you can do a posterior retinotomy. There might be some fluid left at the end of these procedures, but if the lasers are if the brakes are well lasered, the fluid will absorb gradually. Band or not, no band is a personal preference. I, in general, do not prefer a band these days, but it can be done in pediatric RDs or RDs having a lot of inferior PVR to support the vitreous base. Of course, the intersegment cleaning is very important. Cleaning up the PCO in a phakic patient, removing of the cortical matter because they can fibrose and they can cause anterior PVR in the post-op period. Fogging is a big problem if there is a YAG opening in the IOL. So simple maneuver is just go with the visco cannula and just coat the posterior surface of the IOL, and the view is excellent after that. You can also debride the epithelium if the view is hazy and the surgery is going on for a long time. And of course, interface vitrectomy is, I think, all which we have started doing now. And under air, the field is wide, and we can see remnant vitreous which was not seen under fluid. So that is there. This is a giant retinal tear. This was a case of Stickler syndrome with a radial GRT, and we did a core vitrectomy in this. So first, we have to clear up all the vitreous. And then as it was crumpled, there's a gentle unfolding with the bimanual instruments if you're using a chandelier, or by the light pipe and the cutter if you're not using a chandelier. So once we see the disc, we can do furthermore vitrectomy and then slowly inject the PFCL, keeping away the retina with the other instrument. This has to be very gentle and in a non-hurried way because the PFCL can go subretinally. After that, we can check for PVD after injecting tricot or remnant vitreous. As you can see, there is a everted edge, the radial tear. So we gently manipulate it, iron it out, and straighten the edges of the GRT. Of course, the anterior flap has to be removed because it causes ischemia and recurrences, and the folded edge have to be freshened out. You can use a diathermy. I'm not a big fan of diathermy again, so I do not use it, and the chances of bleeding are very less if you control the bottle height and all. So under the PFCL, the 3 or 4 rows of laser is done 360 degree and the edges of GRT. And now there are again 2 ways of doing it. You can do a direct silicone oil exchange. I do not do that. I go under air very slowly, drying up the interior edges of the GRT. That gives me a very good view, a wide angle view. And the slippage chances as described in the literature previously are very minimal. I have not encountered, this is almost a 360 degree GRT. And we are doing the PFCL air exchange, and it does not slip. Only thing is you have to go slowly. These are complications if you tie a band, a very tight band in GRTs. The PFCL can go subretinally as in this case. And the only thing is you have to loosen the band, take out the band if possible, and aspirate out the PFCL and fill up the PFCL again and do the laser. So this is one complication which you have to be careful about. Thank you.